So we're going to talk about peripheral vascular disease. So vascular conditions, there's peripheral vascular disease and then there's deep vein thrombosis. And we're going to cover both of these in this lecture. So peripheral vascular disease, also known as peripheral arterial disease, is a condition that's buildup of plaque or fatty substances in the walls of the arteries that leads to clot formation or decreased blood supply. This is just another image to show you how, the buildup of plaque into the vessel itself and how it really does affect the musculature of the vessel and how well it can pump blood, but also the, ability for blood to even flow through the vessel. Remember, plaque also is sticky, so that's where clots can form too. Isn't necessarily that the plaque decreases the amount of blood supply completely as much as it makes blood stasis, stick there, and end up getting thicker itself and causing a clot formation. So who's at risk for peripheral vascular disease? These are key things you want to know and be able to understand so we can educate our patients on their risk, reduce these risk factors to prevent patients from even developing peripheral vascular disease. So as we age, we all know our musculature decreases. And so those who are over the age of 50 are increased risk. Those who smoke, those who are diabetic, being overweight, thinking about that metabolic syndrome or syndrome X increases it. So it's, not only diabetes, but elevated blood pressure with the obesity and hyperlipidemia. Those who are of male gender, those with a sedentary lifestyle, like I said, those with high blood pressure or high cholesterol, family history of heart disease and vascular disease, those with coronary artery disease, and the African American individuals. So establishing a diagnosis, just like any, really key is getting a good history of present illness, good history of the patient's medical history, a review system, and a physical exam. An optimum environment predisposition, so to thrombosis. Those who have stasis, vessel wall injury, and then hypercoagulability state leads to thrombosis. So this is just a good kind of imagery to get used to and have a good understanding of that triad of who's at risk. The etiology. So there's different types of arteries and vessels we know that can lead to thrombosis. So large arteries would be those at risk for atherosclerosis, thromboembolism, trauma and injury, and then arteritis of various types. Okay. The etiology. So specific to certain anatomical sites, those sites are more prone to having peripheral vascular and clot formation. And then also various neurovascular compression syndromes that affect the upper limbs increase those risks. Same goes for those with medium and small vessel occlusions. For medium and small vessels, there's certain disease processes, certain genetic factors that increase our risk. So the staging of peripheral vascular disease, 75% of vessels may be occluded before symptoms even occur, which is kind of that key thing, which is why we really want to get patients who are at risk and start screening for them. And we'll talk about some of the different screening tools you can do before they actually even develop it. So first sign would be reduced pulses. You notice that the velocity of the pulse is not as strong in one extremity. Then becomes intermittent claudication. Stage 3 is that pain when resting, and stage 4 leads to ulcers. So thinking about the peripheral signs of peripheral vascular disease, the 5 Ps. These are key things you can do during your physical exam to catch. So first would be pain, pallor, pulselessness, paralysis, paresthesia, and 4 and 5 actually suggest surgical emergency. 3, 4, and 5. Types, so there's a functional and there's an organic. Functional is no organic cause, no blood vessels defects that can be short-term or temporary. Organic causes are actually changes in the blood vessel structure and function. Examples would be inflammation, fatty deposits, plaque buildup, blockage, and obstruction. Clinical presentation. So the asymptomatic, without obvious symptomatic complaints, but usually with a functional impairment that's noted, versus the classic intermittent claudication phase, which the lower extremity symptoms confined with muscles, with the consistent reproducible onset with exercise and relieved with rest. And then the atypical leg pain is a lower extremity discomfort that is exertional, but that does not consistently resolve with rest, consistently limits exercise at a reproducible distance. So this is kind of a good table to review to understand intermittent versus venous versus neurogenic claudications. It goes through the different type of pain, the onset, what may be relieving the pain, the location that these are more common, and the legs affected. So kind of a good review for you to review on your own about the different types of claudication. Same thing goes with arterial versus venous. I would have a good understanding on how you're going to differentiate an arterial versus a venous cause for the two different disease processes. So having a good understanding of the difference between pain, color, skin temperature, pulses, edema, tissue changes, and the type of. So this is a good review of arterial versus venous assessment. This is a good review of arterial and venous assessments that we're used to on how we would grade a pulse, with 0 being no pulse and 4+ being that aneurysm past even a bounding pulse. And remember that most people are going to be about a 2+. And the pain scale for peripheral vascular pain, knowing the different grades between a grade 1 and a grade 4, will help us determine the severity of the disease process. And how is peripheral vascular disease diagnosed? Well, a great easy way to do it is doing an ABI. You can have your nurses do this in office. You can print out a little algorithm that's going to be on the next page to help you determine their risk factors, and knowing the patients at risk and starting them on aspirin therapy is a great way. So with an ABI, it's the blood pressure in the arms and the ankles is checked using a regular blood pressure cuff and a special ultrasound stethoscope called a Doppler, which all offices are going to have a Doppler and have a blood pressure cuff. The pressure in the ankle is compared to the pressure in the arm to determine how well blood is flowing. And the index is determined by dividing the ankle systolic blood pressure by the arm systolic blood pressure. So this next slide shows you how this is done and how you would calculate it. And based on the calculation, it will tell you what's normal versus borderline, mild to moderate peripheral arterial disease, and those that have severe. So like I said, we want to catch patients at that borderline. So if a patient has risk factors, this is an easy thing to do in office to determine a patient's risk. You can also do diagnostic and lab workup, getting a CBC, a chem profile, an EKG to rule out cardiac abnormalities, inflammatory blood work such as a D-dimer, homocysteine, and CRP. And remember with the CRP, you want to get that cardiac one and the inflammation one. And then you can also get the interleukin-6 test. Imaging that you'd want to do for a patient, and I wouldn't do this for a patient if they were borderline, I would do your moderate to severe patients, is Doppler studies. Though not 100% reliable, emboli may still be present as the result is collateral circulatory dystole. You can get an MRI, a CT, and then angiography as well. Doppler or duplex ultrasonography and Doppler color flow imaging. A USG allows reproducible standardization of criteria for assessment of peripheral vascular disease, and your Doppler color flow imaging localizes the disease segment through identification imaging, helpful in determining lesion severity. For treatment, is focused on cardiovascular risk modification. So lifestyle modification and education, tobacco cessation, getting patients up and moving, eating healthier diet that's low in cholesterol, low fat. Medications you can start first line aspirin. Exercise training, vascular surgery, revascularization for patients who have severe, and interventional radiology or gene-based therapy. Pharmacological agents, drugs that lower cholesterol and control high blood pressure are go-to first line. You want to decrease blood viscosity, can be used, and then antiplatelet agents. Their primary long-term benefits in reducing cardiovascular events and mortality. So anybody that has coronary artery disease, peripheral vascular disease, go-to is get them on a statin, get them on aspirin. And these are the clinical practice guidelines that you can review regarding management. Other procedures that patients who have severe cases with cardiology referral may need angioplasty, stent placement grafts, thrombolytic therapy, and stent grafts. For gene therapy, the field of molecular genetics has provided new understanding of vascular physiology and pathology and has opened exciting frontier for treatment of peripheral vascular disease. It's directed at transfer by intramuscular injection of DNA encoded with vascular growth factors, has resulted in growth of new vessels and collateral circulation in chronically occluded lower extremity arterial vessels. This is new frontier that's really helping change the way we're treating patients with peripheral vascular disease and preventing them having to go through stents that we know many times can lead to further plaque buildup around the stent and complications. The common surgical procedures, which you do not need to know these, but they're a good review, especially if you have a patient and you're going to talk them through what they could potentially go through. So kind of reviewing these on your own will be helpful in kind of determining what you need to educate patients on. So next we'll talk about is DVTs, or deep vein thrombosis. It's a formation of blood clot deep in the circulatory system of veins. And is caused by any factor, condition, or injury that results in a clot formation in the body, usually in the legs, but not exclusively in the legs. And this just shows you the clot formation in the actual leg and what it looks like in the vessel. Risk factors, so genetic clotting disorders, those that are immobilized for prolonged bed rest and inactivity, which is why now all the hospitals are starting patients on blood thinners. Paralysis, injury or trauma can cause. You think about it, injury or trauma, hematoma, what that is. Surgery and dehydration, oral contraceptives or hormonal replacement therapy, being overweight and obese, which is also secondary many times to a sedentary lifestyle. Smokers, those with cancers and malignancies that can occlude the vessel. Prolonged sitting, family history, those over the age of 60, those with heart failure, bowel diseases that have inflammatory etiologies, pregnancy and postpartum, and varicose veins. Symptoms. Sometimes they're asymptomatic. Swelling in affected extremity, usually unilateral with pain calf. That leg cramps, tenderness, or soreness is noted. There may be erythema, pallor, or cyanosis present. Physical assessment, vascular assessment, palpation of the peripheral pulses, evaluation of cap refill, neurological exam, motor, sensory, reflex deficits may occur in that extremity, and the Homan sign, pain in the posterior calf or knee with forced dorsiflex of the foot. Can be a precursor to PE development. We know that the clot can move, and with that get into the lung and cause a PE. 33 to 40% of individuals diagnosed with DVT develop a PE, and 15% mortality rate with PEs. Symptomology of a PE: shortness of breath on exertion, hypertension, tachypnea or tachycardia, diaphoresis, hematosis where they're actually coughing up blood, low-grade fever, chest pain, and a cough. It's just a review of that triad that we all went through earlier about that hypercoagulability state with stasis and vessel injury all lead to DVT. Diagnosis of DVT, Wells score, you can use compression, USG. Venography is the gold standard for diagnosis. MRI, getting a D-dimer. Other studies would be in nuclear medicine studies that you can do. Another one would be measure the volume of the lower extremity in response to stimuli. This is the Wells criteria for you to review. You add up looking at their risk factors or symptoms or clinical signs, and you add it up and it gives you their probability. There's also the Hestia criteria for PE management with a questionnaire that you'll look at to determine. And if one of the questions is answered with a yes, the patient cannot be treated at home. Common treatment modalities was anticoagulation coagulation therapy. Then you can also do thrombolytic therapy, surgical intervention with placement of filters, and compression stockings. This is the practice guidelines with the algorithms for therapy for you to review. Treatment goals. We also obviously want to prevent a PE. We want to get resolution of the DVT, and we want to prevent, reduce post reoccurrence. There are some newer agents that have been approved. As you probably all are aware, though, there are many lawsuits with these agents, partially because when they were first developed and created, since they do not need to have PT and INR checked like you would with other anticoagulation therapies, they were kind of a huge hit with patients, but then the hard part is they're not reversible. So now with that, they're developing reversible agents for these medications because of the fact that they were having many bleeding issues with these. So it's one of those things that many of these are newer agents that you're probably going to see more and more used. But for a while there, they were kind of being not used because of the risk factor, and you couldn't reverse them with like vitamin K. So patient education and teaching. So we want patients to obviously avoid having another DVT, PE, so we want them to avoid prolonged immobility, avoid possible estrogen therapy. Anybody with a history of clotting disorders, it's contraindicated for them to do estrogen therapy or to do a contraceptive that is hormonal based or estrogen based. We want them to have early ambulation if they're having any kind of surgical procedure, maintaining good hydration, use of compression stockings. We want them taking their medications as directed. Avoid tight-fitting closed hose stockings that are not having compression with them. And they have a low-K diet in patients with warfarin therapy. That's the end of our lecture.